So this is recovery. We have expectations and we have reality. And, you know, at the same time, Roberto said, I try to be in contact with what you said and not make a round table, not make a presentation only. So you said citizenship and also meaning and purpose. So you spoke also about psychotherapeutic techniques. So sometimes we are trapped within psychotherapeutic techniques or our pharmaceutical knowledge or know-how. As psychoanalyst, what it makes sense for me in all this recovery process is the purpose and the meaning. If I'm unable to share or to co-share this meaning with the subject in recovery process, so I will be a very bad analyst, and especially a very bad psychosocial professional or a reformer of what is going on in Greece. So this is how I understand this recovery process. Just read in what you said, Rob. You see, the mental illness, the mental disorder, limits a lot the image of ourselves. Then moving towards new changes, new investments, new opportunities, the sense of self is increasing, and we reduce, I think, the sense and the impact of mental disorder in our own lives. And finally, by the end of this journey, which has not an end, I would say that, okay, we exist, we are ourselves, with a coexistence within ourselves of a mental disorder, which is not a major impediment in order to live a meaningful life and to live and to share with others our experiences and our hopes. So I would like to highlight these controversial expectations in this complex recovery process, which represent also a major challenge for mental health professionals, especially leading mental health services in Greece. The expectations of users are quite different than the expectations of families, the expectations of doctors still believing in biomedical model, which is reducing symptoms, the expectation of employers, they want production, but not meaning and production for the person's life. Donors are quite different, how much it costs. Public system, also the cost, and now we are trapped in Greece in a debate putting together cost and reduction. That's all. We don't have other objectives in the public mental health system rather than how to cut the costs. Not taking into account the quality of care, the quality of life, and also the burnout of professionals who are really sometimes trapped in this terrible condition of crisis, economic crisis. And also sometimes the expectations of community members with stigma and prejudice are the safety. Are we safe? Can we be safe towards the dangerousness probably of a mentally person? So all these things, all these expectations are quite controversial, and a good mental health team, including multidisciplinary members, could overcome in a community work. So another remark, I think complementary to what was mentioned by Roberto and Bob, is the community integration and the community inclusion. 2 words about this, I think for me it's important. The community integration is an historical concept of the movement of mental health, which refers to the process of assisting a person to become re-engaged in community life. But as for instance can happen with prisoners, with immigrants, with HIV patients, etc. But in the case of mental illness, this has meant be cured of your illness first, recover from this illness or overcome the symptoms and deficits associated with the illness first, and then we will welcome you back within our community. This is not a valid approach. According to my view and my vision of recovery, we have to highlight the importance of community inclusion paradigm, which argues instead that people with long-term disabilities should be accepted and welcomed by their communities as they are, as it happens with people with physical disabilities, with whatever conditions they may have, without having to be cured, fixed, or otherwise made to conform to selected social norms. So I think in order to implement this community inclusion, we have to overcome the fear of the alien, the stigma, and what psychoanalysis calls unthought threat, which represents the threat coming from the fear of a schizophrenic person, which is well eradicated in our communities sometimes. So all this has been said by Professor Grove. I would like to highlight the difference between biomedical model and recovery model in functional disability, how it's different with the concept of irreversibility in chronic psychopathology led by biomedical model psychiatrists. When we first came in Leros with triesthetine in '88, the key word mentioned by psychiatrists and nurses working in Leros, in the asylum, was, what are you going to do with these chronic people? These are irreversible, no hope for them. This was the first word heard by their first reaction when we started the deinstitutionalization process of the Leros asylum. And now Leros is producing very good honey, promoted fortunately by Bob Grove in UK. So another very important issue concerning the biomedical model versus recovery model are the resources from psychiatric services and also resources from social network, which can mobilize individual and potential resources. We do not work with a person, disabled person or mentally ill person, without having in mind that he has a lot of potential in order to develop his skills in further activities and new investment and new hope, and also how is possible to exerce the full citizenship mentioned by Roberto. So these are different cultures. These are some different cultures in psychiatric services. We have the culture of care, characterized by helping, but as well overprotection. And we do know in Greece and also in southern Italy, what does it mean, overprotection, not only from family, but coming from mental health service. You may meet in your practice mental health services led by biomedical model, which do not promote any autonomy of the person because they are afraid of their responsibility. Who will have the responsibility to give a space of freedom, a space of creativity for the mentally ill person? If we are unable to take a creative risk, there is no rehabilitation, there is no hope, there is no recovery process. And also the culture of care in which experts demand compliance. For me, and especially compliance by patients in the context of this model. for me and also the staff working in epilepsy in UK services, in Trieste service, the term compliance should not exist. It should be replaced by the term negotiation, alliances, and basic trust, but not compliance. What does it mean to comply with something? With destructive, sometimes with its own side effects medication. This is not a compliance. This is a malpractice. This is not a good practice. I go on about the barriers of recovery, which for me are important in Greece. These are the barriers mentioned by a user's point of view, by Digan, a well-known person, very well known in users movement. Please notice the number 9. Have you embraced the concept of the dignity of risk and the right to failure? Why is it important to succeed in whatever we are doing in our mental health services? We have also the right and the dignity to take a risk with an accompaniment of the person with this complex reality represented by the community. And the number 10, are there opportunities within the mental health system for people to truly improve their lives? If we don't dare, we cannot care. And about the Greek reality, the professional point of view, our point of view is that the financial crisis affecting the care, research, training programs also influences any effort for system integration. Second, the severe budget cuts of psychosocial rehabilitation units put into question the viability of users and professionals. Third, the fragmented mental health system and lack of coordination represents another problem in order to implement the recovery process. Fourth, which is quite important, the burnout in mental health professionals. In the same time, we have to deal with the difficulties and obstacles in order to implement recovery process, and also to deal and manage the despair and the burnout of our colleagues who are not paid since 6 or 7 months. And fifth barrier is frequently conflicting agendas among the basic partners in mental health. Politicians, mental health professionals, also within psychiatric community there is not a unique agenda. We have a quite conflicting agenda in our point of views, the families and the users. And these two slides represent the ex-post evaluation of the Greek public health system, coordinated by our colleagues of Institute of Psychiatry of London. So mainly the fragmentation, the unequal development of services throughout Greece, and the services which are not responsive to their mission and not coordinated practice, weak leadership, represent main obstacles for the psychiatric reform and also for the recovery leading mental health services. And also the number 14 in Greece is very important. Bob knows it very well. We have 4 separate systems in mental health working independently and non-coordinated between public, non-profit sector, NGOs, social security system, and private system. If we'll be unable to unify all these 4 levels of care, there is no real hope for improvement for the Greek psychiatric reform within the economic crisis. And this is the last slide. Ongoing research, a program research, led by our students of Pantheon University, is quite instructive. We have overcome 60% of involuntary admissions in the biggest mental hospital in Athens, of Daphne Hospital, which represents a negative record all over Europe. I think we have overcome even the percentage of admissions in Lithuania and Estonia. Why is that? The reasons for these increased percentages are mentioned, of course, in the obstacles of the previous slides. But mainly, the main reason is, first, the biomedical culture. Psychiatrists will very easily sign the involuntary admission of a person without making an effort, consistent effort, in order to avoid this involuntary admission. A second, involuntary admission within the crisis context, Roberto, represents a research for a psychiatric bed. There is a lack of psychiatric bed, so a family will ask for involuntary admission in order to find a bed for its relatives, which is a distortion, a perversion of a real psychiatric care system. And I finish by telling you something, investing in hope. How can we work in order to overcome the obstacles with articulating this shared vision mentioned by my two colleagues, clarifying roles and responsibilities, providing incentives and rewards that promote this new attitude and behavior towards the biomedical model behavior, and ensuring accountability for partnership. Monitor what everybody is doing in this collaborative model of care as vision for our country. Thank you very much for your attention.